on the fries when we're trying to get to this area. So we talked about it a little bit before. Quickly entering, releasing a tamponade, cross-clamping the aorta, stopping pulmonary hemorrhage. Internal cardiac massage to me is probably, of all of these steps, the lowest priority, simply because there's no point in beating an empty heart. Sounds like a pop song lyric, but it's true. You have to fill up the heart first, and the whole point of this thoracotomy is to fill the heart up as much as you can, arrest bleeding, so that you can have perfusion back to your coronary vessels and to get the heart restarted as quickly as you can, at the same time ensuring some degree of cerebral perfusion. Now, we have laid out some of the instruments over here, and again, you notice less is more. The fewer instruments you have in your kit, the faster it is going to be to enter your chest, because it's going to be a scramble. Space is a limitation. You don't have a scrub nurse, you don't have a big trolley, it's just you and whoever else is around you, and you got to re-roll them for this rare procedure. And again, I think what's important to emphasize is that this is not a procedure just for the surgeons to do. And in fact, every EMD physician here should feel empowered to take on that knife and get going, because time is life in this setting, and you should just start getting going, and models like this help you with the training. So let's get right to it. Now, the start state for any ED thoracotomy should already be the presence of a finger thoracostomy or a chest drain already in situ. Most likely a finger thoracostomy, because in traumatic cardiac arrest, that's one of the first things that you would want to have established already. So in this case, for example, we have pre-made a cut over we are pre-making a cut over the model itself, so that this stimulates the presence of a thoracotomy, which is already a finger thoracostomy, which has already been performed, and any tension pneumothorax decompressed. Once you have done this step, generous cut with a knife all the way from the sternum all the way down. Not a time for hesitation. Just keep going. You can't do anything worse than what the trauma has already done, and you need to go down all the way. You may not, if the patient is in cardiac arrest, you may not get much bleeding at this point, and you will have to reach right until the sternum while you're making this cut. And you go down as deep as you need to. Don't worry about cutting anything else. It's often, the chest wall is often thicker than you think, than what your blade can achieve. At this point, you want to quickly enter the chest. The easiest way to do that is with the scissors, using the entry point that you have already created in the chest with the thoracostomy. And putting a blade there and lifting up will be the easiest way to cut through the entire chest. Now, when you get to the sternum, there are a couple of ways to deal with this. You can avoid sometimes opening up the sternum, but oftentimes you may need to get good exposure. And how do you cut across the sternum? Yes, a good Mayo scissors will be able to do it, but in a cinch and you don't have a jiggly saw, so you don't have any pneumatic saws, a paramedic scissor sometimes does the job. And sometimes just sliding your paramedic scissors into your cavity and cutting through the sternum is probably all that you need to do at that point. In this case, the paramedic scissors has taken a beating, so I will move on from there. Now, at this juncture, you want to put in your rib spreaders. Now, it can be very, very tight sometimes opening up, and you've got to make sure that you make your cut all the way down, so that you're able to get all the way down to the, so there's enough space for your ribs to open up. And it is sometimes this difficult to open up itself. Having an assistant with a bit of retraction will be useful, and then you get your Pinocchio retractors down. Simple device to use. Main pitfall, getting your gloves caught in the grooves over here, which I've done multiple times to try to avoid that. This part always goes lower, so it doesn't get in your way. And here we are quickly applying the Pinocchio retractors. Now you will hear some cracking of the ribs, you will hear some funny sounds, don't worry about it. Eye on the prize, release any tamponade that you have over there and try to get there. Here we can see there's still a bit of muscle left over. I'm going to use my scissors and quickly snip it open here, over here, till we get right to the pleural cavity over here. And here we have then a demonstration of what's happening in the chest cavity. Now this is not going to be and sometimes you've got to reposition yourself to make sure that you get your ribs right under the Pinocchio retractor. Ideally, you do this with an assistant, so you have some help in retracting it first, but if not, you have to make do, because that's what life is about. So here we go, opening up the chest, and as you can see, you should be able to see a little bit of the heart. Now, sometimes you have opened the wrong area. Sometimes you have gone too high and too low. Don't panic. Through your same incision, you can go either up or you can go down and get into the cavity. Do not be afraid to make a separate skin incision if you are way off. Sometimes if a junior faculty has come in and tried to make a cut much higher up, you just have to go in and make the correct cut. The important thing is time and to get to where you need to be as fast as you can.
At this point, you would intentionally intubate the right lung by pushing the E to T deeper so that the left lung collapses.
Yeah, that would be ideal. Now here, what we can see over here in this model over here is a heart. You can see in the brown, this brown line signifies the phrenic nerve, which is in place here. Now at this point, let's take the example that this patient has had a tamponade, which you have seen on your FAST already, which you should have done prior to this because it would have been a very simple thing to do prior to opening up the chest. And what you're trying to do now is quickly opening up the pericardial sac. Many ways to do it, but the simplest way sometimes is just to take a forceps, lift up and cut through the pericardium itself. Not a complicated procedure. If there's a hole underneath, don't blame yourself, it's probably the trauma itself, right? So here what you're doing is you're just taking a forceps and making a simple cut. And when you make that, and sometimes it's difficult to grab one, a tooth forceps is useful, and here we have a successful release of a tamponade, but your job is not done. Whatever has caused this tamponade is still bleeding. You can see again, just to highlight the resilience of this model in being able to replicate the presence of a tamponade in this kind of a setting. Now when you're cutting the heart, it's important to make sure that you avoid the phrenic nerve. So usually we try to enable a vertical line all the way down. Try not to go too horizontal because you want to avoid the phrenic nerve. And at the very bottom of your model, you may need to make a bit of a Y incision in order to be able to deliver the heart successfully out of this model. Right? And once you've done that, once you've cut enough of the pericardium, it might be a bit difficult for you to appreciate the lower part of the cuts. And perhaps I'll direct my camera person to just go a little bit distally over here for you so you can see what it looks like. And when you are going down into the heart, you need to make a Y incision right at the bottom here, as far as you can, or a Y or a T, so that you're able to actually successfully deliver the heart from this area here. And what we see over here is a heart which has been delivered. Now, for the purpose of this demonstration, I'm going to move away, I'm going to just show a little bit under the costal margin so it's easier for you to visualize. But in real life, you would be doing a lot of this through this small incision itself. Now what happens if this incision is not big enough? Sometimes very big heavy set, your finiscitor retractor is not going to be enough. This is where you may want to quickly convert to a clamshell and cross over so you can get excellent exposure to the chest. And do not be afraid to do that. Remember, eye on the prize, release tamponade, stop bleeding, cross clamp. That's all we're trying to do here, nothing else fancy, whatever gets you there, right? Then you would need another finiscitor, which is why every thoracotomy set should have at least 2, so you're able to do that. Now let's say you're in a setting where you don't have a finiscitor retractor, then your helpful assistant with simple retractors is good enough. Alright, but it takes up space, takes up manpower. But a finiscitor retractor is a fairly basic surgical instrument, which I think every thoracotomy set should have, but you cannot make do with anything else. Fingers, I try not to because you tend to get damaged. But anything else can be used to pull things apart. Now, once you've done that and you've released your tamponade over here, now this actually just begins the first part of your journey because you have released the tamponade. You may see some improvement in the hemodynamics, but you may now need to start to stitch the heart. And again, if I bring you back to where the focus of where the heart would be in real life, how you would focus a bleeding spot in the heart. So let's say, for example, I am here, let me make artificially a wound over here. And certainly in the models that you create, you can actually create a wound before that to mimic the presence of an injury. What you would do at this point is put your finger on it. That's probably the most important step you can do at this point to stop bleeding, right? And putting your finger is enough for you to transport the patient to where you need to be. Now, if you have still the capability, if you have done this before, and if you feel confident enough that this is a wrench that I can repair very quickly in the emergency department, you can, but you must be prepared for what goes wrong when you do that. And again, you will probably need someone to help you load up a syringe, to load up a suture, and you try to use a monofilamentous suture when you're doing this. So if you're doing this alone, it's a bit challenging. Sometimes you do need a second pair of hands if you're trying this maneuver. Now, if I remove my hand off this heart, the heart will continue to bleed and spurt. So the technique that we use is essentially stitching next to your vessel. Stitching next to your finger. So with your hand on the heart, you are actually, under visualization, putting your first part of your suture in, removing your finger just temporarily for the needle to come out. And once you've removed your needle, very quickly putting your finger back on. If you have an assistant, this is the time where you utilize your assistant to keep your finger on. Now, ideally, you might need a couple of sutures, and ideally for some of these areas, a pledget, which is a small piece of talc being applied would be ideal. my experience, when you're doing this in the emergency department, talc and felt is very hard. It's hard to find, and you probably don't have it there. All right. If you do, well and good, but more often than not, you don't. And in this case, for example, I would ask Dr. Kenneth here now to put his finger on the wound as I start to prepare and start to tie down. And he removes his finger just at the last moment so that at least you don't lose blood while this is going on. And once you put your suture down, that's when you start to put on additional sutures, and you and if it is stopped, if you manage to maintain your hemostasis, then you're well and good. Right. So now let's moving on away from the heart now.
What's been described as a lead from Paget's is the wrapper of the sutures. Cut small pieces in there as well.
The other technique, which is also quite useful, although it may seem a bit out there, is the use of a skin stapler. So skin staplers that we use for everything else can be used on the heart to great effect as well, especially for the left ventricle in particular. When it's very thick and muscular, a well-applied stapler can do in a stinch as well. So these are some of the other things you could do. What has also been described is the use of Foley's catheters being used to tamponade, but you have to be very careful that you don't blow up the balloon in the myocardium itself. And you go to pull it, and you make sure that your balloon is in the chamber before you inflate your balloon and you apply some tension. Again, this is temporizing. Your operation doesn't end here. Your operation must end in the operating theatre after you transport this patient going forward. So just remember, if all else fails, just press and you're done. Now, let's say you have done that, patient hasn't come back yet. I need to establish some form of afterload so that there's back pressure and the diastolic filling of the heart. Now what we're going to do now then is talk about how you cross-clamp the aorta. And I'm just going to basically use the bottom part of this model to demonstrate that a little bit clearer. So what you will see here, and I'm going to conveniently move the heart a little bit out of the way here, is essentially the fact that the lung has a ligament right at the bottom of it. Right? So the advantage of these models as well is that you have movable parts, which allows you to mobilize parts itself to demonstrate things, but in real life, it's a very tight squeeze. And what you're trying to do now is you're trying to basically lift up the lung. Now the lung is not going to go anywhere until you mobilize the ligament known as the inferior pulmonary ligament, indicated by this little white strap over here. Now this strap has to be lifted up with your fingers, and this is more of something by feel rather than by visualization because of the tight area that you're at. Essentially, you're using your scissors, and I'm not sure they can see that. You can see it over there. This ligament will have to be cut. Now, you don't have the ability to see what you're cutting. It's running your hand over your fingers and making a cut all the way up in order to be able to move the lung until you can reach the hilum of the lung. Now, at this point, you don't want to make sure you cut all the way because you're going to reach the hilum of the lung and you're going to be ending up cutting it. Don't be too worried about these parts as well, but just release a little bit. It should be enough to mobilize enough of the lung for you to find the aorta, which is indicated by this white tubing over here. Now, the aorta, in most settings, is going to be fairly flat in a patient with traumatic cardiac arrest, but it is a muscular kind of a vessel. So if a patient's heart is pumping, you will feel it pulsatile. If it is not, it is honestly quite challenging to feel. And having a nasogastric tube inside will have to differentiate it from the esophagus, which is nearby. In practical example, in real life though, very few people have a nasogastric tube at this point because everyone has been panicking trying to do this, and no one would have had the presence of mind to put in a nasogastric tube. And it is quite reasonable that such a tube is not in at this point. So in any case, you need to basically find where the aorta is and press it, or at least compress it against the vertebrae. And this is your first form of compression. And at the very least, that's the step you can do to restore the afterload. If you're not able to, if you have a bit more facilities, you're a bit more familiar, this is when now, and you need to transport the patient, you can apply a clamp. But I have moved patients to theatres, and I'm sure many of you have done that before, with your hand just on the aorta, compressing it while you bring the patient up to theatre. A bit scary, but doable and life-saving if you can restore perfusion this way. Now, in the event that you have some time and you want to apply a clamp, what you can do is take a scissors, and you can replicate, and usually there's a layer of pleura over the aorta, and you will need to open it up here. We have not created that in this model, but the next generation of this model, we're going to be putting a pleural layer over this aorta so that you can practice cutting it as well and applying a clamp thereafter. Now, these kind of procedures, you can imagine, if you're doing it for the first time, and you've never done even on an animal model, a cadaveric model, or a plastic model, it's going to be really, really, really challenging. But the principle is that at least your pipe pressure if you're not comfortable with any of the other surgical aspects. And in this case, we apply a clamp, and this is a typical aortic clamp on in most thoracotomy sets to provide some compression. And once you've done this, you have actually kind of established as much as you can of hemostatic control from any bleeding below the diaphragm. And this step should help you to basically establish some flow to the coronaries and to the vessels itself. Now, these are probably the key procedures that you want to do. But in the event, for example, we find that this is actually a lesion in the lung. We have profuse bleeding coming from the lung. Now is when you got to try to figure out where's the hilum. And again, it starts with the procedure of mobilizing the inferior pulmonary ligament as shown, moving and holding the lung in your hand, which will lead up to the hilum here. In this demonstration model, you can see the hilum as indicated by this blue structure over here. And you can see my fingers slowly picking up until I capture the hilum. Again, this is not a procedure for the lighthearted. This is not a procedure that's easily done. And it's a lot of it is done by feel. You cannot visualize any of this. It's my hand now. I have no idea where I am, but I can feel that I'm at the hilum, and that's where you need to be. And again, your clamp that you apply at this point is usually over your hand as you apply it over the hilum. So without looking at what I'm doing, I can feel where I am, and I'm applying a clamp. And I hope my videographer has been able to capture that it is successfully clamped and not clamped anything else. I presume that's all right. It feels like it. Feels good. So good. So that's how you control with the pulmonary hilum. Now this is an extremist kind of a procedure. It is very rare that the patient that you clamp the pulmonary hilum goes on to survive. But if you have especially if you have a penetrating injury, it's a crucial step for you to do. In blunt trauma, if you have reached this stage, your prognosis is probably quite grim. But in a penetrating trauma, if you have an injury to the pulmonary hilum, this is a crucial step in order to be able to do that. Remember that you have huge changes in your hemodynamics, huge changes in your flow of air or ventilation at this point because you've clamped off the entire hilum. And you have to be very gentle in these maneuvers because you don't want to cause iatrogenic injuries as well. If in doubt and you're not confident, you just press. And that should be enough for you to get to theatre, call for help, and get going. You will need another surgeon at this point because when you go to theatre, simply because you don't have enough bandwidth to keep holding this while you try to sort out the logistics of everything else is going on. So if I'm a surgeon doing this in the emergency department, I will lean heavily on my emergency physicians to help organize the logistics, the calling, because I'll be focused here and my attention will be on the patient itself. So you got to cross-roll yourself when you're doing this procedure. Finally, the last part, which I didn't want to emphasize so much, was internal cardiac massage. And this requires delivery of the heart out of the cavity. If you don't bring the heart out of the pericardial sac, there's no way you can employ a suitable internal cardiac massage. Lifting up the heart is also problematic because immediately your venous inflow from your SVC and IVC is going to be affected. So again, the heart always be kept at the neutral position, one hand on top, and basically compression between your two hands, mimicking the flow from the ventricles up towards the aortic outflow tract. If you're doing a procedure, if you find yourself in a position or see someone doing this, which is very movie friendly, it's probably not very useful and may be very harmful as well. So your whole hand over, pressing up against. Very liable to induce cramps in your hands when you're doing this. So you do need to get people to stand by, take over, because your hands will cramp up after a short while. Maybe it's just me, but they do tend to cramp up quite a bit when I do this. Right? And at this point, you want to quickly get going to where you need to be next. If you don't have a return of circulation, it's unlikely that you're going to go anywhere back to theatre. And in our hospital, our protocol is we move to theatre once we have some form of return of circulation at these procedures. If not, especially in blunt trauma, if not, the outcomes are going to be very poor. And you have to consider futility at this point of the procedure. If, let's say, the patient does not make it, then, of course, put everything back and we close up as much as we can before the patient goes to the coroner at this stage. So again, this is just a very quick demonstration of some of the key aspects of thoracotomy. Having a model to practice